everyone. It's really wonderful to see so many people here today, and it's a great pleasure of mine to speak to you about an issue that I've been working on locally and internationally for over 15 years, including with many people in this room. What I want to do today is share a little bit of the history of what's happened around supervised injecting sites in Vancouver, and talk a little bit about the early times and how we got there. And then I'm going to talk a little bit about some of the evolving practices and how things started to evolve in Vancouver and how people started to push the envelope and try new things. And then I want to conclude by talking about what I think are some of the next steps, what we really need to do to maximize the potential of this type of intervention. But what I hope I leave you with also is a sense that in Vancouver here, we really have made remarkable contributions to the evolution of this form of intervention internationally. And we've done that in many ways, through not only through research, but also through activism, innovations in programming, people in bureaucratic positions, and even members of the policing community who took a lot of risks to move this kind of controversial intervention forward. Before I jump in, I'm obligated to let you know that I have absolutely no conflicts to declare. So what are we talking about? Well, we're talking about supervised injecting facilities. They exist all over the world, and they are places where people can inject illicit drugs or inhale drugs under the supervision, usually of healthcare professionals, but not always. They really range considerably in design, including sometimes quite colorful, such as these supervised injecting rooms in Switzerland. And there people are able to acquire the supplies they need to inject in the safest manner possible. They can receive education and support, usually from nurses, on how to inject as safely as possible. They can receive emergency intervention in the event of overdose, and they can also receive emergency or referrals to a wide variety of services, often within and outside of these types of programs. And in some settings, these are even mobile programs, such as this one, or this one, which typically are very small and include just a small number of places for injecting. So where do they exist? Well, there's almost 90 facilities around the world. There's about 31 in 25 cities in the Netherlands, 24 in 15 cities in Germany, 12 in 2 cities in Spain, 12 in 8 cities in Switzerland, 5 in 3 cities in Denmark, 1 in Norway, 1 in Luxembourg, 1 in Sydney, and 2 in Vancouver. However, there are new facilities planned for France, who I suspect will open 3 injecting facilities quite soon. Ireland has recently announced their intention to open these facilities, and feasibility work and significant planning has already been undertaken in Ontario and Quebec. And I think you will be surprised in the coming weeks to hear some media announcements about some very small places in Ontario that are now considering implementing these facilities. Okay, but what happened in Vancouver? Well, my read of the situation is it really started with this, which was the overdose epidemic. And as you can see, throughout the 90s, there was pretty much a person dying every day in the province of illicit drug-related overdoses. And this eventually led to the chief coroner, Vince Kane, creating a task force and issuing this famous report, often referred to as the Kane Report, into illicit narcotic overdose deaths in British Columbia. One common misperception about the Kane Report is people think that he actually made a very explicit call for supervised injecting facilities, and in fact the report makes no mention of supervised injecting facilities. What it does mention, however, is a great need to shift the focus on drugs and drug-related harm to a health-based approach from a criminal or enforcement-based issue. And he also called for the massive scale-up of harm reduction, and that for him included heroin maintenance, which some people would argue would naturally include some form of supervised injecting facility. Another important dynamic was that at this time, Vancouver was slowly becoming a place that was home to probably the world's largest open injecting drug scene. And a very important aspect of this was its physical geography. the network of single-room occupancy hotels, and the alleyways, which became open-air injecting environments. People spent a lot of time injecting in there, in part because it was one way that you could try and avoid police detection by hiding in the doorways in the event that police officers would look up the end of the alley and try and see people injecting. And of course, these environments were remarkably unsafe to inject in. There was no access to sterile supplies. If you overdose, you were often left on your own. And they were just generally remarkably unhygienic environments. It was around that time that two important activists got busy. The late, great Bud Osborne, who was a poet and a former drug user himself, and Ann Livingston, a long-time downtown Eastside activist. And around the time of the Kane Report, they started trying to mobilize drug users to advocate for themselves and to find user-based solutions to the problems that were growing and becoming worse and worse in the city. And that eventually led to the opening of Vancouver's first unsanctioned injecting facility, which operated here. This is the Back Alley Drop-In. It operated from about 1995 to 1996. It was run by a user group that was really formed by Ann and Bud called IV Feed. And for Ann and Bud, this was really not just about opening a place where people could drop in and inject with their peers and obtain some support. For them, this was really about empowering people who use drugs. The facility ran from the fall of 1995 to 96. There was an estimated over 100 visits per day that were recorded. It was supported by the BC CDC street nurses who delivered sterile syringes to the facility and provided some other forms of basic support. And although the police were aware of the facility and often visited it during its operation, eventually they closed it. Like many places in the downtown east side, the Back Alley unsanctioned safe injection facility looks very different today. But it was around this time, shortly thereafter, on the heels of the overdose epidemic really taking off, that we started to see a massive epidemic of HIV infection among people who use drugs in Vancouver. And eventually this led the Richmond Health Board to declare a public health emergency, but this too had a lot to do with a lot of the activism in support of supervised injecting facilities. Bud Osborne became a member of the Vancouver Richmond Health Board, and before long, groups of drug users were showing up at every Vancouver Richmond Health Board meeting demanding action on these twin epidemics of overdose and HIV infection. And eventually they released this action plan to combat HIV/AIDS in the downtown east side. Like the Kane Report, this did not call for the establishment of supervised injecting facilities. However, it did call on the federal government to make major revisions to drug policy to make it a health-focused approach. It also called for the scale-up of harm reduction. Following that, a number of community groups, including the Portland Hotel Society and the Carnegie Community Action Society, began organizing events to hear about other experiences in primarily Western European cities that had dealt with similar problems as Vancouver. This event, called Out of Harm's Way, was held one January on a cold, rainy day in a tent in Oppenheimer Park. And it is estimated that as many as 700 people crammed under this tent to hear people like Werner Schneider, the drug policy coordinator of Frankfurt, speak about how they tackled their open drug scene and the problem of overdose in that city, how they were aggressive in opening up 5 supervised injecting facilities, numerous drop-in centers, expanding low-threshold methadone, etc., etc. And people got very, very excited about this. It was shortly thereafter that the Vancouver area network of drug users was formed and began becoming increasingly vocal in their demands for some kind of response to the profound losses in their community. And they lobbied everyone, including the city government, who was experiencing pressure from local neighborhood groups such as the Community Alliance and some of the business improvement associations to stop establishing new services for drug users in the downtown east side. The Community Alliance showed up at several variance board meetings trying to prevent the establishment of new services. They kept losing, but eventually they succeeded in convincing Mayor Philip Owen to put a 90-day moratorium on the creation of new services for drug users. Vandu responded by erecting crosses all over the lawn of City Hall and delivering a coffin to City Council in their chambers. The moratorium was lifted. Shortly thereafter, in this very room, there was a meeting called Keeping the Doors Open. It's funny because Maxine Davis said to me as she walked in, I remember this room back then because Maxine was there through all of this. And a group that was organizing called Keeping the Doors Open, holding a number of meetings to talk about what could be done, had a meeting in here, and at the end of it, Ann Livingston held up a clipboard and said, "Who wants to do something about this? Who wants to get together and talk about supervised injecting facilities?" And I think for me, one of the really neat things about this time was that it was the first time that you had ASOs, aid service organizations, from the West End, sitting down with downtown East Side groups and drug user organizations to work together to find solutions. That eventually led to the creation of a group called the Harm Reduction Action Society. And together we created what was the first proposal for a pilot injection facility in Vancouver. And in addition to reviewing all the gray literature out of Europe, many of it in other languages, it included a very detailed plan for a facility, and it budgeted it down to the very last Band-Aid. And the whole point was really to draw attention to the issue, to demonstrate that it was feasible. Eventually, the city came forward. They released their framework for action, which was the four-pillar approach, really adopted from Swiss models, which sought to balance prevention, treatment, enforcement, and harm reduction. And that was led by Donald McPherson. And this was a proposal that at last finally called for the establishment of supervised injecting facilities as well as harm and maintenance programs in the city of Vancouver. But while everybody was talking and thinking about what to do next, it turned out that there were nurses in Vancouver who were already supervising injecting at the Dr. Peter Center. And it was summed up nicely in this article in the Canadian Nurse in 2002. It says, in December 2001, a nurse was approached by an injection drug user who asked for a rig so he could use heroin. He planned to just shake up the drug with his own aspirated blood because he had no waters or facilities to cook the mix. "Yes, you do," said the nurse. "Come with me." And so began supervised injecting practices at the Dr. Peter Center, with these three courageous nurses leading the way. The Dr. Peter Center was strategic in dealing with this surprising development and quickly consulted the police, who declared that there was nothing illegal happening, in part because the Dr. Peter Center had actually gone to the trouble of consulting the Registered Nursing Association of BC and the Registered Psychiatric Nursing Association of BC, who confirmed for the Dr. Peter AIDS Foundation that it was actually within the scope of registered nursing and registered psychiatric nursing practice to supervise injections for the purposes of preventing illness and promoting health. And at the time, I can tell you as someone who was working at the Dr. Peter Center, this really was a serious issue. There were people who were overdosing in somewhat hidden locations, and they were sometimes difficult to find. And I think this was really, we felt obligated in a way to ensure the safety of the participants of the Dr. Peter Center by including this practice. Eventually, when the Dr. Peter Center moved to its new building in 2002, it opened up this harm reduction room, which includes 3 spaces for injecting, and I'll talk a little bit more about that later. So at this time, when there was a lot of momentum growing for the establishment of supervised injecting facilities, we kind of got to a bit of a wall. And it was really with the enforcement community and some others who said, well, we get it, we understand the potential health benefits of this approach, but it's illegal. And that's where the Canadian HIV/AIDS Legal Network stepped in and played a very important role by producing this report led by Richard Elliott called Establishing Safe Injection Facilities, Legal and Ethical Issues, and it essentially laid out the way in which Health Canada could legally approve these facilities. And it was Richard's report that really formed the basis of the Health Canada document that came out shortly thereafter. They adopted his plan and used the exact mechanisms outlined in this report to allow for the eventual sanctioned implementation of these facilities. Not long after, there was a pretty significant political development in December 2002 when Larry Campbell was elected as mayor of Vancouver. One of the funniest things about this election was there was so much momentum around supervised injecting facilities, so much public support to try something new and different in Vancouver, that every mayoral candidate was basically in a position where they had to say, yes, I would support supervised injecting facilities, because if they didn't, they wouldn't get elected. But Larry was the first out of the gate. He was the most aggressive. He had credibility as a former coroner who had attended many overdose deaths, and people believed he would do it. I don't think anyone, though, would expect that he said that he would have injection sites implemented only 2 weeks later by January 1st. And unfortunately, although I believe Larry was very committed to this goal and wanted to open this facility, instead what we got was a police crackdown. And this really angered a lot of people in the downtown east side, a lot of activists. Our own research led by Evan Wood and Will Small were recording how this crackdown was having immense negative effects on the community. People were being displaced out of the downtown east side. Healthcare professionals who were doing outreach said we can't reach people. We knew that people were being forced into more remote locations and injecting in high-risk manners. And so a number of people from Vandu and the Anti-Poverty Committee who were really angry about this and felt that the city and the province needed to live up to its obligation opened up what became another unsanctioned supervised injecting facility at 327 Carroll here on the corner. And we had the opportunity to evaluate this facility through a couple papers, and we basically came to the conclusion that this was demonstrated really the feasibility of a peer-driven low-threshold model. This facility operated for 184 days and supervised over 3,000 injections. And as you will see later in my talk, they also addressed another very important issue. They were confronted with the problem that many people were coming and saying that they needed manual assistance with injection. And to this point, that hadn't been permitted. But because they were more of a grassroots, community-based, peer-driven intervention, they held meetings to discuss how to deal with this, and they came up with their own protocol. They had a nurse who worked at the site, Megan Olison, and they basically came up with a protocol whereby if you came and you needed assistance with injection, you underwent a bit of an education session with the nurse. You were asked to attempt self-injection twice, and if you were unsuccessful, the third time they would allow you to be injected by a peer as long as they adopted universal precautions and followed the directions of the nurse. The nice thing was that they were actually able to teach almost everybody how to inject themselves. And when I asked Megan, she couldn't really recall an instance when someone wasn't able to inject themselves. But eventually we got our supervised injecting site, the sanctioned supervised injecting site, this building known as Insite, that opened in 2003 in September. But something that I think a lot of people don't know about this facility is it wasn't a simple case of bureaucrats getting it all together and deciding they were going to open a supervised injecting site. In fact, what happened is the Portland Hotel Society directors, Mark Townsend, Dan Small, Liz Evans, etc., they worked with a building owner who had a boarded up building. And quietly and secretly, they worked behind this boarded up building and built what is now really Insite. They called it the hair salon because it kind of looked like a hair salon. It was the code name for it. They worked away, put in their own time, the extra hours, and constructed this facility, and then eventually kicked open the doors and said, look, people, here it is. We can do this. Fortunately, Vancouver Coastal Health stepped up, rose to the challenge. They partnered with the Portland and finished off the construction of the building, brought it up to code, and eventually opened up what we now know as Insite. which has now been operating very successfully for since 2003. It includes around 12 booths for injecting, and on average supervises between 700 to 1,000 injections per day. Our group was charged with the scientific evaluation of Insight, and I don't want to spend a lot of time talking about the evaluation because I know most of you have heard about it before. But essentially there are now over 45 peer-reviewed publications derived from the scientific evaluation of Insight. And we negotiated a unique contract with Vancouver Coastal Health where instead of writing a big report at the end of 3 years, which people could dismiss as being biased or shoddy, we said we will take advantage of the scientific system of peer review and instead write a series of single studies which we will then submit to the world's best medical and public health journals. And only when they pass the test of independent arm's-length scientific review will we speak publicly about these studies. I'll briefly summarize some of the main results. There's several studies using different methodologies showing that the establishment of Insight led to reductions in public disorder, including public injecting and injection-related litter. There's several studies now showing reductions in syringe sharing, and one that's not actually listed here is a follow-up commentary by M.J. Malloy in Addiction that used our two studies and the Spanish study to show that there was a very consistent protective effect across samples and settings for syringe sharing. We saw other increases in safer injecting behaviors which actually generalized outside the facility. Using linked data to the detox admissions databases, we found substantial increases in the actual admissions into the detoxification programs, with the first paper led by Evan Wood being published in the New England Journal of Medicine. In a qualitative study led by Nadia Fairburn, an internal medicine physician who continues to work with us, she found that the establishment of Insight also resulted in reductions of drug market violence against women. And we have two papers, including a 2011 paper led by Brandon Marshall and M.J. Malloy, showing that the establishment of Insight led to a 35% reduction in overdose deaths around the facility. We also knew that many people were concerned that Insight could have several negative effects, so we felt that it was important to also assess the potential of these as well. And we found that there was actually no negative changes in community drug use patterns in the community. There was no increases in initiation into injection drug use because this facility had opened and made injecting easier. And then we accessed Vancouver Police Department's crime statistics and did a before and after analysis and demonstrated that there were no statistically significant increases in drug-related crime in the area after the establishment of Insight. We also exported data to 3 different groups of healthcare economists who consistently found that Insight was highly cost-effective. So one would normally suspect that at this point you'd kind of slam the door shut, the discussion's over, no more academic debate, there's a robust body of evidence. Let's face it, if this was an intervention that was saving middle-aged white men from cardiovascular disease, we would now have these facilities absolutely everywhere. But that's not what happened in Vancouver. And instead, as the body of evidence emerged, so did a worrisome trend, which was the politicization and the misrepresentation of science surrounding Insight. And what was really fascinating about this was it was really led in a very coordinated way by a group of national and international actors. Of course, the Harper conservative government, also the International Narcotics Control Board, an archaic body within the UN system that tries to uphold the UN drug treaties, which were established prior to even HIV/AIDS and are completely irrelevant in today's time, and the RCMP. But another very important part was that Drug Free America Foundation was actually funneling money to Drug Free Australia and the Drug Prevention Network of Canada to undermine the science specific to Insight, and in one of their annual reports actually bragged about how they had made remarkable gains in supporting Stephen Harper's government to turn back the clock on all these absurd harm reduction programs in Canada. And they were aggressive. Because things were getting so bad, eventually the Portland Hotel Society, working with a couple individuals from the Vancouver area network of drug users decided that in order to ensure the survival of Insite, they had to take Stephen Harper's government to court. They first did that in the BC Supreme Court. They won. The federal government appealed to the BC Court of Appeal, and they lost again. They then decided to waste more of your tax dollars and appeal all the way to the Supreme Court, where the justices ruled 9-0 in favor of the continued operation of Insite. And in their decision, they said the minister's failure to grant an exemption to Insite contravened the principles of fundamental justice. Insite has been proven to save lives with no discernible negative impact on the public health and safety objectives of Canada. So at this point, we were feeling pretty confident about things and felt that finally the war was over, but it wasn't. Shortly thereafter, Drug Free Australia, working with the Drug Prevention Network of Canada and the Real Women of Canada. If you don't know them, they're a group of socially conservative women who argue against things like national daycares and creating employment opportunities for women in the workplace, this kind of thing. They grouped together and really went hard at us. This is a glossy report they published, which sole purpose is to try and discredit our 2011 Lancet paper demonstrating an impact of Insite on overdose. The funny thing about it is that the paper published in the Lancet is maybe, 3,500, 4,000 words, and this report has got to be at least 20,000. They pulled up work that Evan Wood and I published 10 years earlier to try and make a case that, the whole thing was cooked. And unfortunately, they succeeded in convincing some of the media that they were right. Barbara Kay from the National Post wrote this editorial saying that the Supreme Court used flawed data to make its decision. And they went even further with this. They lobbied the Lancet to retract the paper. The Lancet looked at their materials and decided not to retract the paper. They tried to publish a series of letters. They were allowed to publish one and then were told to go away. They tried to lobby the Supreme Court. The Supreme Court didn't listen. And so I think they were unhappy. And so eventually what they did is they submitted this letter to the University of British Columbia alleging that myself, Evan Wood, Julio Montaner, MJ Malloy, and Brandon Marshall had actually engaged in academic misconduct. And we were contacted by the Vice President of Research for University of British Columbia and told that we were put under investigation for scholarly integrity issues, which I'm sure you can imagine, even if you feel quite solid about your work, is not a nice thing to hear. We were required to submit all our raw data, all correspondence with the Lancet, to UBC, and it was sent to an external independent arm's-length reviewer who came back all of 4 days later and said, this complaint has absolutely no merit. You should be proud of the work that these researchers are doing. But then the federal government stepped in and acted like what I would say a bunch of sore losers and implemented Bill C-65, which was later introduced as Bill C-2. And essentially what this was new guidelines that had to be met in order to establish new supervised injecting facilities in Canada. It included things like you had to have full support of your local neighborhood. The local police had to support this. So essentially it took decision-making powers out of the hands of health officials who were in charge to make important decisions about health and put it in the hands of neighborhood groups. In other words, they're putting NIMBYism ahead of evidence-based public health intervention. Not surprisingly, when the then health minister announced Bill C-2, she showed up with members of the policing community, including the president of the Ottawa Police Association, who, despite our published work using VPD statistics, said, it's abundantly clear a supervised injecting site brings an increase in crime. Fortunately, the Canadian Medical Association stepped in very quickly. They were actually among the interveners in the Supreme Court case trying to support the continued operation of Insite. And they said the CMA is deeply concerned that the proposed legislation may be creating unnecessary obstacles and burdens that could ultimately deter the creation of more injection sites. We published commentaries as well, basically saying this form of prejudice against people who use drugs should not trump evidence of benefit. Unfortunately, as some of you may have heard, I think it was, 5 or 6 days ago, we had another very important development. And that came from the new government of Canada that, despite being very new in office, announced that the Dr. Peter Centre has been authorized to operate the second supervised consumption site in Canada. So congratulations to everyone at the Dr. Peter Centre for that great development. So here we are. We've made a lot of progress. We had a pretty rough go of it, but we're already seeing some very positive signs from the new government. But really, have we done enough? And I would say not. I think there's a lot more that we can do. And that's what I want to focus on, is a number of under-addressed and emerging issues, which I think we should be thinking about. The first one is this problem of assisted injecting. This is an image published in the Vancouver Sun. This is an all too common phenomenon in the downtown east side. We know that approximately 1/3 of people who participate in the Vancouver injection drug users report that at some point in the previous 6 months they need manual assistance with injecting. And a number of studies out of Vitus have shown consistently that people who require help injecting are much more likely to acquire HIV infection. And in fact, once we sorted out needle exchange in Vancouver, scaled up antiretroviral therapy, methadone, supervised injecting sites, when we now look in Vitus, requiring help injecting is probably the strongest risk factor for acquiring HIV injecting in this setting, but we have virtually no interventions to deal with that. And it was around this time that Vandu, shortly after Insite was established, that Vandu approached me. They were very frustrated because they felt when they were going out and doing outreach, the only people they would see injecting in the alleys were people who needed help injecting. Then they got particularly motivated to do something when one of their founding members, a woman who was almost completely blind and needed help with injecting, was robbed and beaten in an alley from someone who was posing as a HIT doctor who said they would help her with an injection. So that led to the creation of the Injecting Support Team. And this is really a novel, interesting development. Basically, you gotta love Vandu. They're just always like a couple steps ahead, And what they did is they made a very deliberate decision to disrupt the whole economy and practice around HIT doctors. They knew that within their own community, they had people who were recognized as great HIT doctors who people often went to for help. They elected a group of these individuals. They trained them in first aid and emergency overdose response, formed a small team, and they started doing outreach. They'd go into the alleyways. They'd try and find people who needed help with injecting. They would educate them, try and help them inject on their own. And if they couldn't, they would glove up and they would perform the injection for them. But it wasn't enough. They wanted to do more, so they started running a whole educational campaign. They ran a number of very, very highly rated peer-led workshops on safer injecting, a whole series of educational materials. Will Small from our group did some nice qualitative and ethnographic evaluation of this group and concluded that the IST represented a very unique drug user-led response to gaps in local harm reduction efforts, including programmatic barriers to attending the local supervised injecting facility. The injecting support team became very hard to sustain. The problem remained there were a lot of people coming to Vandu needing help with injecting, probably partly because they knew Vandu members were out there doing this work. And eventually, Vandu decided to open its own supervised drug consumption room, particularly for the purpose of providing assistance with injecting. And Ryan McNeil, who worked with our group, worked with Vandu, did ethnographic observations and qualitative interviews at the site. And this is what one individual who received assistance there said: "They won't assist me," referring to Insite. And I told him about that. I said, "You're probably excluding 25% of the population here with that rule." "Oh, I'll assist you. We'll show you how to do it." "Well, what about a blind person? How do you help them?" This volunteer said, "You're at someone's mercy when you're asking them to help fix you. A lot of people contracted diseases that way. As far as I know, this is the one and only place where you can get assistance and not worry about having to pay for it or getting your rig switched. VANDU is definitely keeping the diseases from being spread. And that led Ryan to conclude that VANDU had really reshaped the social, structural, and spatial context of assisted injecting practices in the neighborhood in a manner that really helped minimize HIV infection and other risks, while also allowing people who require help injecting to escape drug scene violence. So what about other underaddressed issues? Well, how about crack cocaine use? This is a figure from a paper led by Kerr, which shows the very dramatic rise in frequent crack smoking in the Vancouver injection drug user study over 3 distinct periods between 1996 and 2005. She also showed that in the latest period, that people in Vitus who smoked crack cocaine on a daily basis were about 4 times more likely to acquire HIV infection. Eventually, she followed this up with a work looking at the issue of public crack cocaine smoking and willingness to use a supervised inhalation facility. She found that about 61% of crack smokers in Vitus reported smoking crack in public spaces, and 71% of those individuals said that they would happily use a supervised inhalation facility if one was available. And it's really not that far of a stretch, because these facilities already exist in Europe, like this place in Geneva. And in fact, when Insite was initially built, it did include a room for inhalation, but it has never been opened. So once again, VANDU, trying to respond to gaps in local programming, opened up a place where people could inhale crack. And again, Ryan McNeil stepped up, got in there, did some ethnographic observation and qualitative interviews, and published this paper. This individual said, "We've got nowhere else to do it. The ones who are homeless, where else can they go? I mean, Insite doesn't let us smoke crack there. We want to do a hoot. There's nowhere to go. We need somewhere to smoke crack." Ryan concluded that there was a high demand for safer smoking rooms, and that this was driven by the need to minimize exposure to policing and drug scene violence, and that should say and stigma. And given the significant potential of safer smoking rooms in reducing health and social harms, there is an urgent need to scale up these interventions. One of the other issues I want to touch on is harm reduction in hospitals, and this is an issue that we've been trying to push for a long time. And for me, as someone who's done work in relation to HIV in prisons, I find it really bizarre that we talk about the principle of equivalence in relation to prisons, but we don't talk about it in relation to hospitals. So essentially, legal and human rights scholars and health experts agree that although prisoners lose their right to liberty and free movement, they still retain the right to the highest attainable standard of health. This means that they should have access to the same programs and services that are available in the community within prisons. But again, we have this discussion in relation to prisons, but we don't talk about it in relation to hospitals. There's something wrong here. And there is a problem. We know that about 44% of drug users in our studies who are hospitalized use drugs while they're in hospital. The common reasons are wanting to use and being in withdrawal, and people are most commonly using drugs in their washrooms. But there's another related problem, and it was revealed in this nice paper led by Mint T, who works with our group. And here she looked at individuals who were hospitalized, who were in our studies between 2005 and 2011, linked their cohort data to the St. Paul's Hospital database, and found that 43% of these individuals left hospital against medical advice. And it's not an insignificant problem. We know from work in the US that leaving AMA is actually associated with elevated rates of mortality. Ryan McNeil followed this up with an in-depth qualitative study among individuals in our cohort study who had a recorded AMA experience. And he asked people, why are they leaving AMA? Well, the first was issues related to pain management, drug withdrawal, and under-treated addiction. But he also found that the social structural conditions in hospital were also driving people out of the hospital. Abstinence-only policies, a lack of access to sterile syringes, and security guards who routinely harass people. Fortunately, there has been some development on this front, and I understand that sterile syringes are now being made available in St. Paul's, but I think we could do more. We could be looking at the potential opportunities afforded by establishing in-hospital supervised injection facilities, and Mint T has recently done this in this paper. And here she found that 68% of individuals in our cohort said they would use an in-hospital safe injection site if one was available. And I thought it was really interesting looking at some of the reasons why. First, so they could stay in hospital, to reduce their drug-related risks, but also to reduce the stress about being kicked out because they were using drugs. What else could we do? Well, I think it's clear here to everybody that many people in the downtown east side are still using drugs in very remote conditions. We know from really nice work done using geographic information systems by Kate Shannon's group that many women who use drugs and do sex work are actually driven to very remote locations as a result of enforcement pressure, and this constrains their access to evidence-based harm reduction services. So why aren't we considering doing what many European cities have done, which is open mobile supervised injecting facilities for these vulnerable women and other individuals who will not travel the distance to a supervised injecting facility. And that's something we know. I remember when we talked about opening a supervised injecting site, then Alberta Premier Ralph Klein said that, oh, that's great, open a supervised injecting facility in Vancouver, now all the drug users will leave Calgary and go there. The data from the supervised injection site evaluation shows that the majority of people who use Insite on a frequent basis live within about 500 meters of the facility, and that many people will not travel much further to use this facility. So this might be one other way we can reach this group. So let me conclude with a few thoughts. I hope I've made it clear that supervised injection facilities are evidence-based interventions. We know they reduce infectious disease transmission, overdose, and increase access to healthcare facilities, and they don't undermine public order goals. Sadly, for not very good reasons, these programs remain very controversial and underutilized. And again, I feel like, like with many other harm reduction programs, we treat them differently than just about any other health intervention. We're not following the natural process of evidence gathering and implementation and innovation. We've kind of been stuck in perpetual pilot status, and it's required the courage of people like the folks at the Dr. Peters Center and Van Du to really continue to push the envelope, which relates to my next point, which is, let's be really clear, it's drug users themselves, local activists, and local community-based organizations that have played a major role in advancing supervised drug consumption programming in Vancouver, which I think points to the fact that we need to continue to have civil society alive and well and playing a very important role in delivering health programming in Canada. I think the next steps are clear. I think we need sites where we can better integrate peers. All the feasibility work showed that that was a clear preference. And I think we're, under the current federal guidelines, we're restricted, not doing enough. We have to do something about assisted injecting. We know that it's a problem. It's associated with elevated HIV risk and overdose. And yet, again, there are next to no interventions to address this. We also need places where drugs can be inhaled. And I think supervised drug consumption program really should be extended to other healthcare facilities, including but not limited to hospitals. And this is really the approach that's being taken in Ontario. They're not looking at a big standalone supervised injecting facility like Insite. They're looking at a more what they call integrated supervised injecting service, looking at how they can operate within existing clinics. And then the interesting research questions will not be, do these places reduce syringe sharing and overdose? It'll be really about, well, how do these affect the climate of these facilities? How do they support people in accessing other programs? And we already have some preliminary, some good evidence from the Dr. Peters Center showing that it helps to that end. But now let's take it further and see how it works in other settings. And I really think we should consider exploring mobile sites. We need to seriously amend or entirely revoke Bill C-2. It's in my estimation, an entirely absurd bill that doesn't really reflect the state of the evidence, and hopefully the new government will be able to do something about that. But if I could leave you with one final message, it's really simple. It's like, let's get on with it. Let's scale up. Let's innovate. Let's continue to evaluate and really try and take this to the next level. Supervised drug consumption is by no means a panacea. It's a very, very small part of the continuum of services that we should offer to people who use drugs. However, it can save lives, prevent infections, and connect people to health services. And at this point, we're nowhere close to recognizing the potential of this form of intervention. I want to conclude by first and foremost acknowledging the many research participants in our studies, in the VITAS study, the ACCESS study, the ARISE study, and others who share their personal experiences, their intimate details with us so that we can produce this research. The many staff who work with our group at the Urban Health Research Initiative, our community partners, in particular Vandu, WARS, the Portland Hotel Society, and the Dr. Peters Center, among others, Vancouver Coastal Health and the Ministry of Health, our funders, in particular the U.S. National Institutes of Health, CIHR, and VCH for their past funding for the evaluation of supervised injection site. And I also want to just acknowledge friends and colleagues because, I've just covered for you about 16, 17 years of experience, and it started with many people who are in this room who really put in a lot of energy. And I like the way Dan Small described it in his article in IJDP. He said it was like a collective cultural wave of kindness that happened, where people really got together and they just felt like they needed to do something about all this suffering that was going on. But certainly a lot of good friends and a lot of hard work put in. Thank you for your attention.